Vet Triage. We are finishing up this edition of Veterinary Surgery, April 2022 edition. We're going to be talking about dog TPLO, the tibial plateau-leveling osteotomy, evaluation of a crescent saw guide for tibial plateau-leveling osteotomy and ex vivo study. For those who are interested on cranial cruciate ligament disease in dogs, as well as the different surgical repairs. So feel free to check that out on my channel, one of my older videos. This study comes out of the University of Florida, and the objective is to evaluate the effectiveness of a novel crescent-shaped tibial plateau leveling osteotomy saw guide, which is a crescent guide, to assist with saw control in novice participants. Ex vivo study, 54 synthetic bones, 36 medium-sized dog pelvic limbs. The picture you see below there, that's the typical TPLO that most of us will perform. This large metal frame here is called a jig. You place a pin distally in the tibia and then one proximally. You can't see the pin here, but there's another pin behind the saw. This is a semicircular saw that cuts through the bone, and then we rotate this top portion, we rotate it this way caudally, so in this direction, and then put a bone plate and screws. And that's one surgery of many to repair cranial cruciate ligament deficient stifles in dogs. This study is looking at, can we develop a guide to help with the saw cutting part, because this is the most stressful part for new surgeons, and avoid the need for this entire apparatus. There were 6 participants. They were interns and residents performing a TPLO for the first time. And the results showed there was no difference in the distance of eccentricity. The distance of eccentricity, they say here that if you imagine like a dot right here over this part of the bone, and you draw a circle making this dot the center of that circle, and then you draw another circle to where you want to make this cut. So let's say it's here. The dot in the middle of the circle where your cut is will obviously be a little bit off compared to the circle where this dot is the center of it, and that difference in the two circles is this distance of eccentricity. So there was no difference in the distance of eccentricity. There was no difference in coronal or axial osteotomy angulation between the 3 alignment devices for synthetic bone models or cadavers. The average medial cortical damage with the crescent guide was 3.8 millimeters squared, and that was lower than the radial guide at 35.7 millimeters squared, meaning that this novel crescent guide had less damage than the typical radial guide. And can also compare it to the standard jig, which is 51.2 millimeters squared. That's this apparatus here. 5 of 6 participants preferred the crescent guide over the standard jig and radial guide. Right off the bat, I'm going to say that although I understand their point of using interns and residents, meaning doctors that are inexperienced with TPLO, I think it's dumb, because in real life, interns and especially residents in like their first year, maybe even not their second or even third year, depending on the program, they're not doing TPLOs. So it's just silly to have this. I'd be more okay with the surgical residents doing this rather than interns, either general or surgery interns. But I get it. It seemed like they didn't have enough people to participate, and so they forced having more inexperienced for more inexperienced doctors joining the study. So I just think that's just dumb. But I mean, it makes sense for their goal of the study, but it just doesn't make sense for real life. Anyway, introduction. There is poor control of the radial saw. That's this saw here, which can lead to complications such as malalignment of the bone, unintended cortical damage, imprecise leveling, tibial tuberosity fracture, and implant failure. Much of the learning curve for the tibial plateau leveling osteotomy involves developing accurate osteotomy positioning and attaining proficiency, which requires approximately 50 TPLO procedures. The jig, which is that device here, is secured to the pins and provides a visual reference for saw blade coronal alignment during the osteotomy. The jig also maintains alignment of the proximal and distal segments while the tibial plateau leveling osteotomy plate is being applied. Recently, a radial saw guide was described, which I don't have in the picture here, and I've never used it before. The convex margin of this saw guide is used to stabilize the inner concave surface of the radial saw blade during the osteotomy. This saw guide therefore aims to facilitate positioning of osteotomy in the sagittal plane. Osteotomy accuracy and angulation are comparable with and without the use of a regular jig. While the radial saw guide appeared to improve accuracy, these osteotomies were still found to be distal to the targeted position in almost 70% of clinical cases. They developed as the crescent-shaped guide, and it was aimed to assist with the osteotomy initiation and prevent the radial saw blade from sliding distally, as well as delineate a more clearly defined saw pathway compared to the currently available radial saw guide. This is a three-dimensional rendition of this crescent-shaped from different angles of the tip. Materials and methods: they aimed this osteotomy for a 24 millimeter diameter radial saw. So that diameter is this. This is about 24 millimeter in this study. Here's a picture. The blue portion is like where it outlines where the cut is supposed to, be for the tibia. And then here is an example of the student or intern or resident rather trying to use that novel crescent-shaped guide to help with the cut. And then this is examples of different issues that happened. The yellow circles show damage done to the cortex unintentionally from using the crescent-shaped guide. Oh, and here's the distance of eccentricity. See those two circles, the yellow and the green? So that's what I mean by there's a difference there when you measure the two circles. All right. Results: TPLO using bone models. There was no difference in the absolute distance of eccentricity, the axial osteotomy angulation, coronal osteotomy angulation when you compare the standard jig, the radial saw glide, and the crescent guide devices. Cortical damage was lowest for the crescent guide method. The radial saw guide and the jig required the most time to apply. Crescent guide. The osteotomy using the crescent guide was faster to execute than when using the radial saw guide. So they're saying that their invention here caused less damage and is faster to apply. Using cadavers, there was no difference in the absolute distance of eccentricity, axial osteotomy angulation, or the coronal osteotomy angulation between the standard jig, radial saw guide with the jig, and the crescent guide methods. The crescent guide required the least amount of time to apply. The time required to perform the osteotomy was not different between the methods. And then finally, they had a questionnaire for the participants. They thought the crescent guide was easy to apply, made the osteotomy easier to perform when compared to radial saw guide. They also felt the crescent guide was easier to apply than the standard jig. There was no difference in the perceived difficulty of performing the osteotomy between the crescent guide and the standard jig methods. However, 5 out of 6 participants scored the crescent guide method as being easy overall than the standard jig method. There was no difference in the perceived accuracy of the osteotomies between the 3 devices. 5 of the 6 participants in this study preferred the crescent guide method over the standard jig and radial guide methods. All right, so discussion. Let's see here. Discussion. The crescent guide did not improve osteotomy accuracy with respect to coronal and axial angulation. Although there was no difference in positioning of the osteotomies between the 3 devices, osteotomies performed with the crescent guide resulted in minimal medial cortical damage. 1 second, guys. That's that. So although there is little clinical relevance with reduced medial cortical damage, it is likely representative of an improved ability to avoid chatter when using the crescent guide, particularly because participants perceive that the osteotomy was easy to perform. In patients where the intended osteotomy may not be clearly marked, the crescent guide may result in more accurate sagittal positioning of the osteotomy. So what they're saying with the chatter is that when you try to do the saw, so this part of the saw here, sometimes if you're not aligned properly or your aim is off, it'll start to like vibrate more, and that's of course bad for the patient. And you also can ruin the saw, the blade. It is important to know that the crescent guide is not an equivalent substitute for the jig. It only aims to replace one function of the jig, which is to aid in aligning the radial saw during the osteotomy. The jig has additional functions such as transiently maintaining fragment stability, facilitating plateau rotation, and aiding in controlling the final fragment positioning. Challenges with the jig placement include the need to avoid intra-articular pin placement and repositioning of misaligned jig pins. So that's it. So that's my only comment really with this study is that, ideally you'd have like the surgeons who actually do the surgery trying this technique. So there may have more reasons for doing it this way. I think it seems kind of lazy, but so be it. It's a good start, and I always like when they try and invent things to make these surgeries easier. I think that's kind of cool. Thanks for supporting the channel. We'll see you again tomorrow. Bye-bye.